Got it. What can I say? Finding the right link seems to be the story of my life these days. So, good morning. I'm Christine George, and I'm on the faculty of Curl here. And I'm very excited to present this work that I realized started a year ago. That I think that at that point, AARP and its partners put out an RFP, and we got a call and said, hey, would you be interested in applying for this? And then we at Curl contacted some partners, Jean Solokoff, I'm sorry, Sokolek, and Teresa Kilbane, and who are faculty at social work, along with Diane Williams, a graduate student, and we put together a proposal, and we started going, and we had assumed that that this would start. And I should say to you that COVID became a very important part of this report. However, the Disrupt Disparities, as Mary will tell you, started well before that. And because of the election, and because this was always supposed to be something that was being for advocacy and to get out there and get into the media, that a report that was supposed to be done, that was originally for August, we ended up being until the end of the year, and it has been released now. And so without further ado, I mean, I want to mention one more person who's on this you'll be hearing from, which is Emily Drain, who was one of the Curl team who was involved in this project. So Mary, why don't you take it away? And Mary, by the way, I should introduce, is the Director of Advocacy and Research for Northern Illinois AARP.
Thank you, Christine. Hello, everybody. I really appreciate you all having me here today. And Parvati, you can feel free to start up the presentation, and I'm going to walk you through the different work that we did. I'm really appreciative to be here today. We had such a fantastic experience working with Christine and the Curl team. Now, I want to let you know this Illinois Disrupt Disparities initiative that we just launched is actually part of a larger national initiative that AARP is doing. AARP has built into our new 3-year national strategic plan a focus on racial disparities and racial equity. And so Illinois is one of 12 states that is doing a Disrupt Disparities initiative. We're kind of the third state out of the gate. And we're using this to integrate research, advocacy, and community engagement for a multi-year initiative to further adults of color. So today what I'm going to do is I'm going to walk you first through the research that Curl did and their findings. And then I'm going to take you to our legislative agenda we created, and then also our community engagement and rollout plan. That's the next slide. There we go. So before the Disrupt Disparities opportunity came into being for Illinois, we actually, in our Illinois office, were already exploring how could we address racial inequities among older adults in our state. And because we were very frustrated that there was a lack of focus on these issues at both the state and the local level, especially when it came to older adults. But in 2019, we saw a political shift and a real political opportunity. And we had a brand new governor and we had a brand new mayor in the city of Chicago, both of whom have run on a racial equity platform. We have new state legislative caucuses that were building a racial equity legislative agenda. And we also have a philanthropic community here in the state of Illinois that really wants to focus on racial equity issues. So all of these things came together and we did discussions in our work and said, you know, this is the time to be raising the issues of older adults and those racial inequities that we're seeing. Next slide. So So that is when we decided to build a collaboration with 3 of our statewide partners: Asian Americans Advancing Justice Chicago, Chicago Urban League, and the Resurrection Project. And the 4 of us together, as Christine said, we reached out to Loyola Center for Urban Research and Learning and said, hey, we want to do a broad literature review on the economic security, health, and connectivity issues that are affecting older adults of color in the state of Illinois. And so Loyola did a fantastic job. I mean, Christine and her team looked at over 125 different studies, white papers, gray papers, data sets, et cetera, to really put together a rich and verbose report that we'll be walking through right now. Now, this research was, as Christine said, we started that in May and it went through in September. And then because of COVID, we decided, you know what, we're going to add a COVID report as well. And so we took a little extra time for that and then released the report in January. And while the results of this research are not surprising, they're as devastating. So next slide. So on economic security, this is what we found. So we found the median income of whites who are 50 and older is 1/3 more in the state of Illinois than African Americans, Latinos, and Asian Americans 50 and older. We'll break that down even more. African American older adults are more than 3 times as likely to live in poverty compared to their white counterparts. Older Latinos, 1.7 times as likely, and Asian Americans, 1.2 times as likely. But I think the data point that really hit us the most is this last one, which has to do with home ownership. Almost half of African American, Latino, and Asian American homeowners over 80 years old still have mortgages on their homes. And that's twice as high as our white counterparts. And here's why that is so important. As we know, the most effective tool for intergenerational wealth transfer is home ownership. We also know with COVID right now, and we saw this back also in the 2008 and 09 crisis, is that home ownership, when you have that mortgage, makes you even more vulnerable to changes in the economy. So with the oncoming potential tsunami in home foreclosures, that makes these older adults particularly vulnerable financially. Next slide. Now on healthcare, what we learned is that African American, Latino, and Asian American older adults really suffer higher rates of chronic diseases compared to their white counterparts. And particularly in Chicago, this is really quite high. 75% of older African Americans and 64% of older Latinos have hypertension as an example. And then we also saw that there was a significant amount of what we called healthcare deserts in the state. So in urban areas, healthcare providers and pharmacies are concentrated in white neighborhoods. And when you look at outside of Chicago, across the state, whites are 3 times more likely to have access to transportation and to a car, making it easier for them to actually get to healthcare. When we looked at healthcare coverage, we looked at 2 different age groups. We looked at 50 to 64-year-olds, so folks who are still working, and then 65 and older, folks who are more likely to be retired. And we saw healthcare coverage issues by race. If you look at that 50 to 64-year-old, while only 6.1% of whites do not have healthcare coverage, it increases with the other racial groups. So 11.5% of Asian Americans, 11.7% of African Americans, and here's what's really disturbing. Over 22% of Latino older adults, about 50 to 64, lack health insurance. Then if you look at that 65-year-old range and older, it's even worse. Latino older adults, 65 and older, are 18 times more likely not to have health coverage. And with Asian American older adults, that's 13 times as likely. And remember, this is the population that's supposed to be covered by Medicare. And so that means Medicare is not reaching these vulnerable populations. Next slide. And so connectivity, and this issue is particularly important right now with COVID-19. And what we learned is that more than 1/3 of African American and Latino older adults do not have internet access in their home. And this is for a couple of reasons. First of all, low cost is actually not that low cost. In Illinois, that's defined at $60 a month. And then also technology skills are creating barriers as well, with 48% of older adults needing help. And we're also seeing in Cook County, 41% of older African Americans and 36% of older Latinos do not have a computer. And this is why this is important, especially right now during COVID-19. Looking at the vaccine rollout, the way you get an appointment for a vaccine is through an internet connection. If you do not have that internet connection, you are not getting your vaccine, you're not getting access to healthcare, you're not getting access to programs that can fight social isolation. So you're starting to see bigger and bigger and bigger divides because of that lack of connectivity. Next slide. We also work with our AARP research team, who took the American Community Survey data and actually made geographic snapshots of about 10 different communities in the state of Illinois based upon race and age. And we looked at things like population, household income, poverty rates, SNAP benefits, healthcare access, and home internet access, which allows us to actually localize these issues when we're working with state legislators and local government. There we go. So we also did 2 additional white papers as appendices to the report. And the first one was on lack of Asian American Pacific Islander data. This was the hardest data group to be able to really dig down into, which is surprising and a little frustrating in the state of Illinois, because in Illinois, there's over 670,000 Asian Americans in the state, and 186,000 of them are over the age of 50, but this is the fastest growing population in the state. So this population is only going to get bigger. Now, when we were able to get data and be able to break it down, what we were able to find is that 8 out of 10 older Asian American residents in Illinois speak a language other than English inside the home. I'm giving the impression that there could be some barrier issues. And then we could also saw different levels of poverty. 1 in 5 Chinese American older adults in Chicago live in poverty. 1 in 4 Korean American older adults in Chicago lives in poverty. But here's why that lack of data is so important and needs to be addressed. Because data gets to resources, to be able to apply for government contracts, to be able to make the argument to philanthropic institutions that these communities need to be invested in, that comes from data. So by not the data, we can't make the whole population more so. Next slide. And then COVID-19, we decided in the middle of this pandemic, which we did all of this work we did together virtually, we decided we needed to add a COVID-19 report. And so the data you see here is actually based on January 2021 data. And what we found is that 96% of the COVID-19 deaths in Illinois are to individuals 50 and older. So COVID-19 has been absolutely devastating for older adults in Illinois. And if you break that down even further, it's particularly harmful for older adults of color. You'll see here 18% of the deaths are to older African Americans, 15% of the deaths to older Latinos, and 3.7% of those deaths to older Asian Americans. And then if you look at Chicago, where there's higher populations of older adults of color, those numbers are even more devastating. We're seeing 39% of deaths are African American, 32% of deaths are Africans. Next slide. Now, the purpose of that is to really create change. And so now I'm going to take you through how we used all this fantastic data to actually get impact. Next slide. We've put together a state legislative agenda that we're currently working through Springfield right now. And it's made up of basically 4 pieces of legislation. But as actually each day goes on and we're working with legislators, we're actually adding to this list. So on economic security, we are pushing a bill to expand secure choice. Secure choice is a state-run, employer-based retirement system, which makes it possible for employees who are working for an employer who do not have pension or 401k programs to actually be able to save for retirement. We want to expand this program right now to smaller employers. Right now, it's only for employers who are 25 employees or older or more employees. But we have learned that the majority of African-American, Latino, and Asian American adults work for employers that are under 25 employees. So we want to expand this program to cover all employers with one employee or more. We're also supporting a senior property tax deferral program, which makes it possible for older adults to age in their home and defer the higher property taxes that we're seeing in the state. We are also pushing a telehealth bill. So during the pandemic, Governor Pritzker put in several executive orders that require healthcare insurance companies to cover telehealth visits. We want to make these executive orders permanent, and we also want to extend the coverage to caregivers for these older adults as well. But directly connected to telehealth is, of course, connectivity. And so we are pushing a bill right now that will target high-speed internet expansion to communities of color by expanding the Broadband Access Council to include actual specific representation from organizations that represent African American, Latino, and Asian American communities. Next slide. We also have a larger agenda, which we know will take multiple years. We want to create emergency savings programs, since we know that many times just an emergency cost of $500 can send a family into poverty. We want to lift the age cap on the earned income tax credit, so older adults who are still working but are low income can take advantage of that tax credit. We also are working on prohibitions to evictions and foreclosures, and are tracking several different bills in order to take some actions for what we know is going to be just a wave of evictions and foreclosures resulted to COVID. We're also looking at investing in health equity models and also increasing healthcare coverage for 50 to 64-year-olds. And then finally, we also are starting to explore municipal broadband networks. We're in discussions right now with the City of Chicago and with Cook County. Next slide. Now, to do all this, though, all right, you got to build the community support. You got to build those coalitions. So our 4 organizations are doing a 4-phase rollout plan. We're engaging public officials. We're doing launch events. We're doing cascading virtual events. And then we're also doing a joint summit. So we'll go through each of those. Next slide. And to set you up for that, this is how we're telling our story.
See just how much more pronounced these disparities are, especially in vulnerable older adult communities.
Across all these communities of color, the infection rates are somewhat higher than for white populations, but what's much, much higher are the mortality rates. And you can come all the way back to lack of basic access to healthcare, but also lack of access to an internet connection that in these days can be the difference between getting any kind of help and not.
My parents tried really hard to give us as stable and normal of a family life as possible. As I got older, I became more aware that my parents actually didn't have a lot saved away, and they hadn't really thought about themselves and what the future might hold for them.
Almost half of older adults 80 and over still carry a mortgage. And when you're talking about those who have retired, who are on fixed income, what does that mean for people? And how difficult is that?
This isn't just an issue that is unique to one community. This is something that I think is a political problem, is a policy problem, is an information problem, but certainly is a really golden opportunity for different communities of color to work together.
We learned things and researched things with our partners around economic security, around access to healthcare and services, and around digital connectivity.
I have lived on the south side of Chicago in the same house since 1968, and I'm 90 years old. I was losing my home, and I was like 9 months behind. Mary's story, unfortunately, is very common in the African American community because until we repair the problems of disparities, we'll continue to fall behind the average homeowner. We have this huge problem in the city of Chicago with affordability. When seniors come to the Chicago Urban League for counseling, that's the first thing they say: I don't know how much longer I'm going to be able to stay in my house. Because with my income shrinking, everything is going up, but my income is staying the same. We may be forced to go live with our children.
Many of these families are still owing on a mortgage past their 70s. And so that's a challenge if we want to make sure that there is generational wealth transfer.
It didn't start with our current seniors. It started from seniors before them and before them. There's a history. What we need is to have a real investment in the African American community. We need hospitals and medical centers that really care about the community.
It's so important for all of us to continue to be connected. In the state as a whole, about a third of African American, Black, and Hispanic Latino older adults lack connectivity and broadband access. So when we look at how we can connect with others, older adults are losing that gateway. About 7 million older adults in the state of Illinois are homebound. The issue of telemedicine, staying connected, is more important than ever.
In many of our communities, the digital literacy gap is very, very high. A lot of our families don't have access to the internet, don't have access to the hardware. And so even new innovation in the medical field online has been a challenge for our community as a result of not having access to the internet in significant numbers.
Advancing Justice Chicago is very grateful to AARP for helping lead on this so that we can make sure that the stories of our parents' generation, the stories of our seniors aren't forgotten or ignored.
It's very important that our state legislators understand that as we go through a recovery effort, that they see investing in addressing these inequities as something long-term.
The best way to arm yourself for effective advocacy is to have good facts and data. So armed with this, we expect to be even more effective on the advocacy front. There are all these disparities, but they are things that we can get at if we focus on the right set of policies.
Yeah, so that's an example of we can do incredible research, but we got to be able to tell the story in order to get effective change. So as part of that rollout that we did, before the report was even released, we did pre-briefing meetings with the governor's office, the Black Caucus, the state Senate president, as well as the mayor's office and different state agencies to get buy-in from our political leaders on our legislative agenda so they could be standing with us and working for these changes. Next slide. And on February 8th, we did a great virtual launch. And of course, now we're in the virtual world, we have to do this. So we had our 4 organizational partners with us. We had 3 legislators who are taking our bills through the state legislature, as well as lots of different community members stand with us. And in fact, we even had our press conference was even Zoom bombed by President Tony Preckwinkle. So it was great. We got really, really great press coverage on being able to take this rich, incredible data and be able to connect it to how do we actually make impact. Next slide. And we got really super great coverage. So Chicago Tribune, WBEZ, Chicago Sun-Times, also downstate media outlets as well, to really tell the story about how racial equity is affecting older adults of color in the state of Illinois. And so really taking the data that Loyola was able to identify and then connecting it directly to real life issues, and then showing how we can address those through the legislative change. Next slide. We've also created a group of cascading virtual events. So basically almost every week between February and April, we've had a different event. We launched these with the first event on No Data, No Justice, which worked with 15 different Asian American community organizations to talk about the lack of adequate data for older adults and how we can address that. And then we'll be doing a series of events focusing everything from faith leaders to our Urban League partner affiliates. We've also been doing some different events in Spanish and having bilingual discussions about issues, and then kind of wrapping it up with a racial wealth gap discussion with banks and other community leaders in the beginning of April. Next slide. And to cap off this first phase of work, we're actually doing a Disrupt Disparities Joint Summit with the Illinois Department on Aging. So ourselves and our 3 collaborative members are working with several different foundations and about 18 different working group members to put together a 2-day virtual conference with speakers from across the country. And we'll be talking about the 3 different areas: economic security, health, connectivity, but most importantly, the virtual summit, we're going to have calls to action. We're going to have calls to action for state legislators to say, yes, we need to get these bills passed to get moving on these issues, but also a call to action for the philanthropic community to continue to more into these racial equities for older adult issues. And we're also going to give a quick preview on our next round of research with Disrupt Disparities 2.0. Next slide. So we are going to continue our work with Loyola Curl, and we're going to be doing a Disrupt Disparities 2.0 report. That research will be starting this summer and will conclude in the fall. And that research is going to focus on social isolation, caregiving, and nursing homes. Our collaboration, when we were working with Christine and the team at the initial data, we were like, you know what, these are issues we want to dig into deeper because this seems to be the most important for our various different communities. This will be our opportunity to do that. At the same time, AARP Research, which is part of our national office, is also doing a deep dive into nursing homes and the racial inequities here in Illinois as well as different states to research to reports released in the fall. Next slide. So this is truly just the beginning. We see this Disrupt Disparities initiative as at least a 3-year initiative, and we're using this to kind of get started. But we would love you to visit our website, disruptdisparitiesil.com. At this website, not only do we have the report with the executive summary, as well as that video you just saw, but we also have registration for the joint summit that will be happening April 26th and 27th. This website will be the kind of virtual home for the entire initiative and will be built out over the 3 years. So we're really excited about the work that we did with Christine, the team, and Curl, and we cannot wait for the next steps and would love to discuss the work that we've done.
Thanks. Thanks, Mary. I just want to give you a heads up that your video really seems to be lagging, so you might want to turn your camera off. The good news is the audio is just fine.
Okay, I shall do so.
So yeah, we can go from there. And then I think, Christine, you're going to take over for a bit here. You're still muted though, Christine?
Okay. So one of the things we thought we would do next is, this was a very exciting and very iterative process in terms of this project. And it really talked about how research can be tied to advocacy, and advocacy needs research at the same time. And also how to disseminate or really get this, you know, at Curl, we talk about actionable research. And to me, that this was an example of actionable research. So I wanted to really start to have a discussion initially with Mary and some of our colleagues, and then open it up for a fuller discussion about any of the things that we presented in terms of the data and in terms of the trends we saw, and whatever questions people have. So Mary, one of the questions I had to you is, why did AARP start the Disrupt Disparities strategy? I mean, and exactly what is it? Why did they make it a priority?
Oh, sure thing. So, and as we look at the demographics of the United States is aging, right? So by 2050, almost a majority of the population will be over the age of 50. So we know that the population is aging. Not only is it aging, but it's also diversifying. So a perfect example is if you look at Illinois, we used to be a state that was predominantly white, like 85% white. That has definitely shifted. And here in the city of Chicago, we have a third African American, a third Latino, and a third white with a growing Asian American population. So we knew that we were shifting as a country and shifting as a state. So that was one need. Also, when we looked at the needs of our members, we looked at the issues that AARP has been traditionally working on. And then we were looking at the issues of our Asian American, Latino, and African American members. And they were the exact same issues, but they were even more challenging for systemic reasons for our African American, Latino, and Asian American members. So which meant that many of the solutions that we were working on to do research and policy development that would take the work that we were doing at AARP at the federal and state level and do it even further. So we wanted to dive deeper and see what systemic changes we could make, not just like base level changes to make things look a little nicer, but actually can shift systems to make that difference. And so our CEO, Joanne Jenkins, on our last strategic plan was like, we want to make this a top priority. So examining racial disparities and racial equity and using that as a frame across all of our work is the top priority within our new strategic plan.
So, how does AARP fit research in, and how do they use it?
Oh, sure. So many times when people think of AARP, they either think of the discount you get at Denny's or they think of health insurance. We are so much more than that. So we have a section of our organization that's focused completely on advocacy. And that's at the federal, state, and local level, but we actually have an entire section that's on policy research and integration. We have a public policy institute, and we have a whole center for global thought leadership. So we're doing research that is immediately applicable to the advocacy work that we're doing right now, but we're also doing research that's looking at 10 years, 20 years, 50 years, 75 years out. We have a whole group of researchers that are actually looking at the longevity issue and looking at that along racial lines to see what are the long-term impacts of the racial wealth gap, et cetera. And then if we made these changes, what changes would we see not just 10 years from now, but 50 years from now? We do a lot of extensive work that way too. So, and so we have ongoing research projects that are constantly happening at AARP, and we're actually starting to do some international research as well.
Well, what international research?
So we're a global thought leadership team has actually just started a longevity study that is comparing US longevity rates with Europe as well as with China. So, and they're looking out to seeing what those longevity rates are up to about 2050. And then they're actually just right now identifying the academic institutions they're going to be working with in Europe and in China. They're hoping to start that work in 2022.
Okay, so getting back to our the Illinois project, how did you craft that? How did you build the partnerships?
Oh, sure. So we've been working with Asian American Advancing Justice, Chicago Urban League, and the Resurrection Project on small projects, small advocacy projects for years. And then when we decided at AARP, we really wanted to dig deep on this. We knew we're experts at aging. We are not experts at race. And so we wanted to reach out to our partners who also openly said to us, hey, we are experts in our community. We are not experts on aging. So we're like, okay, let's bring our expertise together and address this. So we started out first having some initial conversations one-on-one, and then getting together as a collaboration and kind of talking about what are our strengths as organizations and where do we need to educate each other. So we spent several months in those kind of internal kind of getting to know you, how do we want to structure this conversation? And then we decided, we really want to set a baseline to really see what the picture is, because we realized we had, at AARP, we had a good idea of the kind of the aging picture in Illinois, but not by race. And our colleagues had a good idea about how things were set up for their racial communities, but not by aging. And they openly admitted they actually hadn't thought very much about aging. And so we're like, let's set groundwork. So we worked together, and you should have seen our original agenda was even broader than what we actually ended up with. But we're like, we need to do a broad literature review, just an idea of where we are right now, where are we starting? And that's really how we set it up. And then Christine, as you said, we had a fantastic iterative process with you and your team to kind of like, okay, this is what we're dreaming of. What's actually realistic? Like, what can we actually do? And I love the way, Christina, how you took us, okay, this is what we found. And then you also really educated us on not only the benefits of data, but also the limitations of data. And that because of the way sometimes data is collected, we might not be able to tell the story we want to tell because it's just actually not clear from the data right now, which was also that we wanted to go into. And Asian American Pacific Islander data is a perfect example of that.
Yeah. So, I mean, when Mary and I were thinking about this presentation, one of the clear things is there were all of these problems with the data, and we had our basic bucket of data is we weren't doing any original research on our own. I mean, this was a very small grant and a very small time frame. And so what we really wanted to do is, as I said, is to do a literature review. And one of the things we found very quickly were the limitations of the data. So I just think we want to do some discussions about that. But first, Mary, even before the limitations, could you talk a little bit about some earlier work that AARP was doing in Chicago, I think it was, and the limitations of the data there, and your beginning discussions with the city about that?
Oh yeah, so we just in 2019 during the Chicago mayor's race, we did a citywide survey of older adults in Chicago, and we used that survey as the basis to engage the 15 different mayoral candidates, and it was very educational to see how little the candidates knew about the issues of older adults in Chicago. What that survey also then showed us, because then we then tried to take that survey, like, let's get some additional information to now engage into this new mayor and her new administration on these issues. And we're realizing, oh my God, this data is not being collected. So a perfect example, the very beginning of COVID, when we were starting to see rates, we're engaging with the city of Chicago mayor's office. And they're like, you know what, we're not seeing, that there's much positivity going on in the Latino community. And we're like, wait, what? No, we know that's totally not true. We know that anecdotally for working with our members and with our volunteers. And we said, well, aren't you collecting data on race and on age? And they're like, So we worked with the mayor's office, and she immediately put out an executive order to start collecting data on race and on age, and collecting that data in such a way that we can actually look at age and race together. They were actually originally not doing that. They weren't collecting the age data at all. And we use that same argument with the state, and we're still working with the state on improving their data collection as well. So it's making us realize we need to educate our elected leaders. They have good intentions, but they don't have the data. And so we need to be working with them on how they're collecting data. And then once we get that data, using that data to educate them on different policy changes they should make.
Yeah. You know, and as I said, that we were doing a literature review. And I think that there's a lot of limitations in the literature review. And I was wondering if Jean could talk a little bit about some problems that she found with the health data. I mean, Jean teaches a lot of courses on older Americans and health, and she really is an expert on it. But what sort of barriers did you find?
Well, in some ways, I was the luckiest of the researchers because the federal government and other entities have been collecting data on healthcare disparities for years. So I had some really good starting places. I think some of the issues with the data, though, it's not always broken down in the ways you want it to be. There's data on ages and healthcare disparities. There may be data on communities of color, but you would really have to do a lot of extrapolation to put it all together. The other issue is, I think what it's interesting is to be doing research in the middle of things happening, because like with the COVID, the numbers were changing day by day. And so, you know, do you stop at some point? Do you keep going with the new numbers? So I think healthcare disparities is one of those areas where we do have a number of points of data. It could be a little better sometimes, but I think we could start to look at policy because we do know some things about healthcare disparities. I think that my collaborators, I think they may have had a harder time finding some of the data because it just doesn't exist.
Yeah. Yeah, Diana, what about, or what happened with you? I mean, you worked on all pieces of it. You and I worked on the economics a lot together. And you and Terry worked on especially on connectivity and communities, but especially you did that special report on what data existed for Asian Americans. And what did you find? What were the problems there? Or, I mean, with the data?
Yes, so thank you, Christine and Curl, for giving me this opportunity to work on this report. It was great to work with every single team member here. And, you know, from our research, two main issues emerged surrounding the AAPI data. Okay, the first one is, you know, a better understanding of the overall landscape of the need for AAPI older adult community, right? So we were not really clear as to what these needs are. And what I mean by that is, how does the older adult AAPI community look in general? So, you know, taking economics and taking poverty as one example, often the AAPI community is associated with the model minority myth. And unfortunately, that comes at a cost to the AAPI older adult community in particular. So with relatively higher employment and income rates, you know, that hovers around $30,000 for those 50 to 64. What is less understood is how that income plummets. All right. So for those 65 and over, for those 65 and over, AAPI older adults have less than $10,000 a year to live on, okay? And that's the lowest income of all racial groups. So that's just one example. And to Mary's point, in Chicago alone, 1 in 5 Chinese American older adults and 1 in 4 Korean American older adults live in poverty. And that's 25 and 20%, 20 and 25% respectively, right? So, and using this example of poverty, there's a second issue of disaggregated data. So when we're talking about poverty, you know, we also need to kind of take into account the diverse portfolio of ethnicities within the AAPI collective, right? So 5% of Filipino Americans, 13% of Vietnamese Americans, 20% of Pakistani Americans live in poverty, and how there's a lack of data which reflects that, right? So current AAPI data, it doesn't fully capture and it doesn't fully reflect the disparate needs of the variety of ethnic community members that we have. So, you know, this is just an ongoing struggle that the AAPI community needs to further advocate for in terms of research and representative research, right?
Yeah, I mean, and the other thing that I really struck me a lot was, you know, when you talked about that cliff that that sort of has dropped off, and a lot of that cliff, and we're getting more data on it, but we still don't have a clear enough picture, is because of the aging of the immigrant and undocumented or documented population that came here very late, so that the sort of safety net we have with Social Security and Medicare, Medicaid, they aren't eligible for a lot of that. Or they're working in areas which aren't covered. And so because of that, you don't see that, for example, among African Americans who definitely, you see the inequality and inequity that happens with them and how it's reflected in the in their age. They don't have that drop off cliff to the same extent. I mean, they're low to begin with and they get a little lower, but they're steady. But a lot of the Latino and Asian community, you see a real cliff. Once they stop working, they don't have anything. They don't have the kind of infrastructure that's in place to really help them in their retirement years or in their last years. Oh, it's not last year's, it's just the
And
next
Christine,
segment of life.
if I could just say, give an idea of like the power of data, I wanted to let you know that one of the data points that like strike a lot of the state legislators that we meet with is that data point about the 65 and older, that how Latinos are 18 times less likely to have coverage and Asian Americans are 13 times less likely to have coverage, because the immediate reaction is, well, we have Medicare. We have Medicare. I'm like, no, it doesn't cover these folks are not being covered, which means there's an issue. To me, that says we got to dig into that data-wise. Like we got to do some research there to find out, is it because of documentation issues? Is it because of language barriers? Is it because what's the issue that's keeping folks away? Especially since here in Illinois, we just recently had signed into law that Medicaid now, folks who are 65 and older and undocumented can qualify for Medicaid. So be like, well, are we starting to see a shift in that now since we've had this new piece of legislation become law? So I think it's an area of research that is rich for diving into, that we could have an immediate impact of taking that and turning it into actual state policy.
And I think connectivity is also an issue. And Terry, I turn to you for a lot of this in terms of the data that we found, but more likely the holes in the data and how we really had to piece something together.
Mm-hmm. Yeah, that was very true. Because even before we got to connectivity, my overall assignment was community. So I was looking at food insecurity, transportation, environmental justice. And I think we got to connectivity, one, because at least there was something there, and two, because it relates so much to health because of telehealth and because of COVID, just having to be aware and have some kind of connection to learn more about how this COVID-19 was impacting them. I would say out of all the sources I looked at, only I think the American Community Survey let me have some information about connectivity by age and by race, and possibly by location as well. So that was like a gem. It was almost like a trifecta, you know, to get all that information. Otherwise, I either had a lot of data about older adults and how they felt about technology and being connected, or I had a lot of sources about race and what were some of the barriers there. So it was really hard to get age and race in the same kind of report. You know, and then you have some kind of, you know, journal articles that were more based in other cities and locations, and we were trying to concentrate in Chicago and in Illinois. So there was very much a problem with getting data by both race and age in the same kind of data source.
Thanks. You know, yeah.
And Kristen, I'm going to jump in again and say once again about how data can make a difference. So Teresa, we've taken that challenge that you found, which I agree, the ACS data is so much better. And we learned through that process because of your challenge. We reached out to our policy colleagues in our national office at AARP and said, you know, what's going on? Maybe can we look at Federal Communications Commission data, FCC data? And they're like, oh yeah, well that data, we can't really trust that data either, because the way they determine whether a geographic area has broadband access is too broad. So you could be in a census block in Bronzeville in Chicago, and it will say, oh yes, there is complete broadband access in this neighborhood. Well, that's because there's a library in the middle of that census tract. That library has access, and so that entire census tract is then said to have access. So we can't trust those maps. So AARP is the Advisory Council, and we've taken this to the Broadband Advisory Council and saying, look, the data sucks. We got to change the data. We cannot be making decisions on how to invest in broadband access with faulty data, because there are huge pockets, according to the ACS data, of access to broadband based upon race and age that the FCC data that you're basing your investment decisions on not picking up. And so that's turned on some light bulbs there about, oh, we need to be doing some additional data research to make sure that we're actually making correct policy decisions.
Yeah, I mean, the other thing that I saw that I was trying to look at that console and see what they were doing and what data that they were collecting. That they're relying on the federal data, and that they're not doing any sort of what reality is happening in the different communities. And then also, I mean, in terms of aging, they weren't focusing at aging at all. I mean, they were seeing it as an economic development issue primarily, and then more recently as an education issue in terms of the children being able to connect, or students being able to connect for educational purposes. But they really, or as you said, they were looking at the library. They weren't looking at how households or how places where people live and how they can get broadband access. And then there's the whole, I was very shocked. And I mean, that what is affordable and what is, what is considered affordable. And it's like $60 or higher. I mean, that's going to be difficult for a lot of people, besides not having computers or not having the equipment. Yeah. One more, I just want to go on to one thing and then we can broaden the discussion out. But I wanted to go on to a little bit to looking at, as Jean was talking about research while it's happening and the data is changing. And so I really wanted to ask Emily Drain, who was an undergraduate fellow on the project and really did a great job in putting together COVID data, and what were some of the issues that you faced in doing that?
Yeah, thank you, Christine. Yeah, I mean, as you mentioned first, I mean, the biggest issue is, obviously things are changing so quickly as we're writing this report, you know, so it's like week to week, month to month. The data we have is not up to date anymore, you know, and this is an unprecedented new situation. So the way that data is being collected and the way that it's being reported on is not necessarily centralized. So if you're looking at different geographic levels, the things that they're collecting and the things that are being made publicly available, you know, so like for an example, at the county level, you know, you can publicly access information on infection rates and hospitalization rates, you know, but then information on, you know, actual mortality is not available, you know, and then that information is not necessarily going to be available by age and race, you know, but what I do really want to like point out and highlight, as like Mary mentioned earlier, was just definitely the importance of, you know, the collaboration and like the advocacy on part of AARP and working with the city of Chicago to like, you know, really make the importance of more nuanced data a part of the conversation, you know, and working with the city, not only to collect that data, but then to make that available to us as researchers so that we can really, you know, highlight the importance of that and highlight the importance of, you know, making that available and making that part of the conversation.
Thank you. And finally, I want to ask one more question, and then we're going to open it up and we can talk more broadly. But Mary, you know, you talked about talking to the legislators and you talked a bit about, you know, what really struck them. But how do you use research? Why is research important? And how are you using it right now in terms of these issues?
Sure. So the research actually makes the issues we're working on real, right? So we at AARP want to connect the research and the data to, as we work with legislators, are like, well, what's happening with my constituents? Right? So that's when we identify constituents in their district that actually personify what the research tells us. But if we don't, but I've been pleasantly, I won't say pleasantly surprised, but pleasantly reminded as we've been using this data to push our legislative agenda, that when we get the pushback of like, we don't think this program will actually have an effect, or this problem is not as big as you think it is, and be like, well, let's look at the data, right? About healthcare coverage for 65 and older, for Asian Americans and Latinos. Folks, if we wouldn't have made that argument without the data, these legislators wouldn't believe us. And so by showing them like, no, look, the data shows that coverage is not happening. Medicare is not working for this population. That forces legislators to pay attention. And so the data gives us the power.
Okay, well, I think we want to open it up to a general conversation. I did see there was one thing in the chat. I think, Emily, you're in charge of this, right?
I think Carol had a question. Carol, do you want to unmute? There you go.
Sure. And I know this seems kind of superfluous, but I guess, you know, I've been a member of AARP for a long time because I'm old. But I did not have an understanding of how much research goes into, you know, that AARP is doing on behalf of older Americans. And I guess what I've been always saying is, oh, well, these are the benefits, these are the things that benefit me from AARP. And this dialogue and this presentation opened my eyes to the fact that my dues are going to help the situation of other older people. And I think that's something that I just didn't have an awareness of. So my question is, how much of your research is funded by things like dues? You know, where else do you get your money? And thank you very much. This was really eye-opening. Thank you.
So yes, that's $16 a year you pay for your AARP membership is funding this work. So do know that. So I actually don't know the percentage of funding for our research department, about how much they get from outside funding versus inside. I do know that we do not take any government funding for anything, research or anything else. We are not receiving any government funding. I do know we do a lot of partnerships with foundations and with other research institutions, but my understanding is that when we do partnerships with other research institutions, we are actually funding them. Not that we are getting outside funding, but I'll have to confirm that. But most of the funding for AARP comes from members just like you. So, and then also we have another side of the house that we literally have no connection to whatsoever, which is, our discounts and the health insurance and all that kind of stuff. That also is a separate income generator for us, and those funds are immediately invested into the work that we do as well. So all of our advocacy work, program work, community engagement, the money that we make through those kind of private sector endeavors is reinvested into the social mission aspect of our work.
Very good. Thank you. Anne, I see your hands up.
Yes, we're getting way more than a discounted by joining AARP.
So thank you very much for the presentation. It was very interesting and always good to know the facts, let's put it that way. But I did have a couple of concerns. One, just a little history. Before the 1930s, the majority of nurses were working out in the community and they were providing primary care services. And nurses are still out in the community doing that. And the majority of them that are out in the community are working for federally qualified health centers, providing care coordination to the population that you're speaking of. And I was just wondering where the community health centers were in this research, because they also are collecting significant data, and I'm referring more specifically to Access Community Health Network, which operates a network of 35 federally qualified health centers across disadvantaged neighborhoods in the Chicago area. So one, I want to raise up that when we're talking about health, we really aren't talking about hospitals. Hospitals are really damage control, okay? They're trying to make sure that people don't die on their shift. But if you're really talking about health, you're talking about primary care nurses and community health nurses working out in the community. And so that's a very, very important point, because right now, in terms of reimbursement, many primary care nurses aren't being reimbursed for their services within primary care clinics, which is something that, I'm very invested in. But I guess I would urge that as this research goes forward, that you really define clearly what you're talking about when you address health, and that you look at the community-based resources that are working with the populations that you described in your study, because they also have very detailed data about their health status. So that was number one. The second is that I get about the disparities, with the broadbands and the computer and all that. But when you're talking about an older adult population, do you really think with their chronicity of illnesses, I guess my question is, what majority of them are really capable of learning at this point how to engage with sophisticated electronic communication? Because during the pandemic, I am, a power of attorney of health for one of my friends, and she's in a long-term care facility. And I thought, well, this would be great. I'm going to get her an iPad and we're going to be able to communicate. She couldn't retain how to work the iPad. Okay. So I think you got to be very careful about where you're putting your dollars when you're talking about expanding the broadband to an older adult population that may be suffering from multiple chronicities. Then my third point is that largely the report that you're giving is reporting deficits. And I guess I'm wondering, along with deficits, there has to be strengths within a community. And those strengths are the things that you want to build on. So what are the strengths that you identified, or did you not focus on that? Because I think there needs to be a balance. Yes, it's clear we've got these deficits, but every community has strengths. So what are the strengths that you're going to pull on to begin to change this? Because health policy is very important, but the change at the community level, engaging people who live in that community, are also going to, I would sustain over time. So anyway, I'll be quiet now.
And you've given us a lot to think about
I'm
here.
sorry.
I'm going to, that's a three-parter with some.
I know, I'm sorry, but.
So I will turn to Christine and Mary to jump in a little bit here and at least, give a bit of a response.
Yeah. I gotta.
You were unmuted before. You just muted yourself again. There you go.
Okay. Yeah, there's so many things. First of all, I just want to say, I think that, there were, this report had one goal. It was to look at the data that was available in terms of disparities. It wasn't trying to describe, but I agree with you that part of the thing that's happened is we haven't, that there isn't the data that really describes the reality in communities, and there needs to be more of that. But the access to data is only the data that was published, the public health data that was published. And one of my frustrations is, in general, that a lot of the health data is held within organizations, and there's not a way to share that in a larger way, except as they have to report to public health organizations. So I just want, I think that is part of the issue. And I agree with you, because I think another, and one of the things we're going to do is in our next study that has been identified is the issue of social isolation. And part of that is that you can only do so much using a computer, but that people are isolated, they don't have the connections. And in terms of health, one of the issues was also transportation, because part of the issue is that there was in the non-urban areas that there needs to be a way to get to the healthcare providers. I think there just needs to be a lot more of public health nursing. And
well, yeah, absolutely. And I would say to you that access provides transportation.
No, that's great. That's great.
Because otherwise the people wouldn't be getting there.
Right.
Yeah. So they do provide it. They pick up the tab for that so that they can get their people, in. Now, that was pre-pandemic. Right now, their clinics are closed and they're all doing telehealth. So it's making it very, very difficult, in terms of the population that you're talking about, in terms of, a lot of times they're using phone, but even that, is compromised at times. But I would just like to hold up that,
even models.
Well, yeah, and even in this pandemic, the role of the nurse in the community and the significance of having a solid public health plan is kind of overshadowed a little bit by the heroic efforts in the ICU. And believe me, I'm not taking anything away from those heroic efforts, because they are significant to people who are in that level of disease process. But what I'm saying is, if we had a more effective public health plan and financing, would our ICUs be overrunning with people? Okay, that's the real crux of it, because that level of care is the most expensive. And now I'll be quiet.
And Anna, thank you for that. I think you actually have made a really important point about the lack of attention paid to public health in general, which I think we've been exposed on nationally and otherwise. Mary, I want to, before I get to Jean, you're up next. Mary, do you want to respond in any way to some of the issues raised by Anne?
Oh, yeah, and I'll try to keep it short because I could go on probably for a half hour on each of these topics. So Anne, I just want to say yes, and. So on the community health, I want you to know that AARP, our Global Thought Leadership section, and our research section is actually doing considerable work on examining models of community health that can be replicated across the country. So we're looking at community health worker programs. We're looking at visiting nursing programs. We actually have a whole institute on nursing within AARP. And so we're doing significant work on looking at those models. In fact, I'm actually on a working group that's looking at health equity demonstration projects that can be, that AARP can partner with at various states across the country and that we can then replicate across the country. So there's multiple efforts going on within AARP on just this issue. On the broadband, broadband is a multiple point issue, right? It's the investment in the broadband access itself, but then also it's getting the hardware to people. And then that issue that you brought up, Anne, is like actually the uptake. So one of the things in AARP is that we've hired a nonprofit called OATS, Older Adults and Technology Services, that actually provides training and input, training for older adults to become more comfortable and take up technology tools. And yes, technology is not a panacea, right? It is not the answer, but it is a piece. And this pandemic definitely showed us the absolute necessity for folks to have access to that technology. I cannot tell you how many hours I have spent with the state of Illinois and Cook County and the city of Chicago and saying you cannot have all of your information being accessible on a website. You must have a phone, you must have a phone line. You must have outreach, you must have mailers, you must have these different ways. At the same time, we still need to be able to make access to those technologies to those older adults because that's the way the world is going. So we need to be able to we want to make sure that older adults, particularly older adults of color, are not left behind. On the deficit focus aspect of it, here right now in this initiative, not just in Illinois and elsewhere, of pivoting from disrupt disparities to build equity for just that reason. So on a branding perspective, we're doing that, but also the focus of the work. So the first part of this initiative was to actually make legislators and state decision makers even recognize that there is a problem, right? So thus the focus that older adults of color need to be focused on, and there are these disparities. As we move forward, then we want to switch into, and here are the strengths within communities that we can actually build upon. So it is a process, but we have to do a lot of baseline education with our decision makers.
Thanks, Mary. Jean, you've been very patient with your hand up there.
Okay.
I'm glad it's only a virtual hand because
Yeah,
otherwise,
right.
Yeah.
A couple of things. When we're talking about people as opposed to technology, I think we have to remember from a policy point of view that many of their things that happen in old age started when they were much younger. For example, what you make in Social Security when you retire is based on what you made when you were 22 and how long you worked. In this pandemic, it's been many women in low-paying jobs who have lost their jobs. So they're losing quarters of Social Security and they're not paid as an equal to men. So that's a policy issue that we need to do for people that are younger. So when they get to 65, it affects them. But Anne, you brought up, one of your comments brought up something I think we have to remember. We've become smarter in knowing that that the older adult population is not a homogeneous population. I think AARP starts at 55. I live in a building with a lot of 100-year-olds. And so when we're talking about what older adults can do, and I'm one of them, I think we have to be careful in making assumptions about everybody in the group. And I think that it applies to everything in this day and age. That's it.
Thanks. Terry, I see your hand up there.
Yeah, to build on Jean's point, like I said, there was very little data on race and age together. But if you look at racial disparities of any age group, I mean, this is starting early, so you can imagine by the time you get to 50, 65, 80, the impact's even going to be more difficult. So cost is like the major one barrier to connectivity. So if people have not been able to be on the internet and learn how to use it and have it as a part of their everyday life or in their home, then it's even going to be more complicated by the time they get older. And the American Community Survey data actually shows different dips in time of usage, like at 65, it starts to drop a little, or everybody's a little bit normalized, and then at 80, very big dips, which of course could be attributed to the type of disease and mental capacity somebody may be going through at that time. So you really have to kind of start earlier, because they're suffering from the disparities they had when they were before 50, before 65.
Thanks, Terry. Other questions or comments from any of our presenters or others in the room? I'm hesitant to unmute myself only because my dog has chosen to start chewing on a very loud, very large bone at this point, which if you can hear it, it's a little disconcerting. I want to let you know I'm fine. She's not chewing my leg. Yes, any questions? Mary, otherwise I will give you the last word here.
Well, I want to say thank you. It has been incredible partnering with Loyola's Curl Center on this work. We are so looking forward to this next new phase and this new round of work that we'll be doing on social isolation, nursing home, and caregiving. I hope that what you come away from the session with is that the work that you all are doing with research and data can have direct consequences on policies that affect people's everyday lives. And then I also hope you come from this that knowing that AARP is a partner for you, that AARP has extensive research, thought leadership, policy creation, et cetera, that I hope you all take advantage of as you continue your research projects in different ways. Think of us as an opportunity to partner and as a resource for information. So that door is always open. I hope we can continue.
Very good. Thank you so much, Mary. And thank you, Terry and Jean and Emily and Christine and Diane for all the excellent work on this project and for sharing it with us today for a really good, robust conversation and discussion. So thank you.